The presentation will be provided by Cody Johansen, that works for UHIN, and UHIN is the State of Utah Health Information Exchange Network. I'm sure Cody is going to provide an introduction to UHIN, but I just want to share with everyone that when I moved to Utah, I was impressed by the work that this organization is doing, the work that is doing to provide access to patients and providers to patient clinical information. And they have this project that is called the Share Identification Services that Cody is going to describe today, that is key in order to share the clinical information accurately between health systems. So thank you, Cody, for doing this presentation today, and we can start when you're ready.
All right. Well, thank you very much, Damián, for the introduction. And once again, I'm Cody Johansen. I'm the Director of Operations for UHIN, and I'll give a brief kind of description of UHIN, overview of UHIN, and then we'll get into the meat of the presentation. So just really quick to start out, UHIN has been around for 25 years now. We work on serving the healthcare community. We first started, our mission is to help improve the quality and reduce the cost of healthcare, and our vision is to improve interoperability and the use of data to improve healthcare as well. So we started out actually as a healthcare claims clearinghouse. So we process administrative claims for insurance, and that started about 25 years ago. And then about 10 years ago, the state decided that we wanted to leverage the great work that UHIN had done as a clearinghouse and set up a statewide healthcare information exchange. So we work as a unbiased healthcare community data trustee, and we work with all kinds of different organizations. We work with hospitals and doctors' offices. We work with insurance payers. We work with accountable care organizations, state governments like the Department of Health. We work with EMR vendors and practice management systems, and we work with other healthcare information exchanges, among many other things. So, our role is really to be that unbiased healthcare community data trustee and be in the middle and be there to help get all of these disparate sources connected and disparate organizations connected. So we really have three lines of business. As I mentioned, we started out as a claims clearinghouse, and we call that line of business UTranscend. And that covers, claims management, eligibility determination, revenue cycle management, prior authorizations, attachments for claims, and then a file tool as well. So those kind of all fall under the UTranscend umbrella. The other umbrella, the second one, is the CHI, or the Community Healthcare Information Exchange, or Clinical Healthcare Information Exchange. And within that, we have an alerting system that's used to be able to say, okay, this patient just was admitted to the hospital. Let's notify their PCP that they've been admitted. And then when they're discharged, same thing, send a notice. There's the records exchange, which is what most people think of whenever they think of a healthcare information exchange of, okay, patient A goes to a new hospital. The new hospital needs records on patient A, so they get the records from the old hospital and look at those. Their results delivery, so being able to process lab messages and radiology reports so that providers can receive those in their EMRs and in their own workflows. Identity management, which is kind of the reason why we're talking today, and that's related to both identity management of patients as well as identity management of providers. And then finally, there's a protocol called Direct that's used for secure messaging that is part of the CHI services as well. And then the newest line of business that we have is actually an analytics business, and we're really just bringing the analytics up. So we're kind of in beta with all of the products for the analytics, and that includes some dashboards as well as just some generic reports that we've created so far. But we're really excited because we see with the move to electronic medical records and more data that analytics is really driving a lot of things and going to drive a lot of things. So we're interested and excited to be able to start that line of business as well. A little bit more detail about the CHI. So in our records exchange, we have over 6 million patients with data. We have over 56 million clinical messages or discrete data points basically within the system. We're connected with all of the major hospitals and healthcare systems in the state of Utah. We've still got a few small rural hospitals to connect with, and then we're connected with a large number of the clinics and other facilities. And then through another project that we have called Patient-Centered Data Home, we're actually connected with several other HIEs and a lot of other facilities. So yeah, we've got quite a few connections and a lot of data flowing through the system. I kind of mentioned the CHI alerts before, but we'll just go over this real quick. The CHI alerts, it's a way to be able to know when a patient has been admitted or discharged or transferred to another hospital so that a provider can follow up with that patient and follow up with them in real time, or at least know that they were somewhere and that they need to be followed up with. It's delivered via different methods, including that direct secure messaging that we talked about, includes SFTP, or even as HL7 messages that are sent from EMRs to other EMRs. So the Patient-Centered Data Home initiative I mentioned a little bit, that's actually an initiative that we helped kind of found here at UHIN, but the idea was to connect with all of the other HIEs that are throughout the United States. And from this map, you can see where we're connected to. The kind of like darker bluish black, those are states where we have full connections. The bluish, aqua blue is where we're partially connected. So for example, in California, there are several HIEs and we're connected to a few of them. And then we're working on connections to like Alaska and Texas and Louisiana and whatnot. But the concept behind Patient-Centered Data Home is that even though there are geopolitical borders, such as state borders, that we sometimes define, patients don't necessarily adhere to those geopolitical borders. So, for example, there's a part of Utah in the southeast corner that it's actually easier for them to go to Colorado to get treatment and to get follow-up. So they actually usually travel over to Colorado and get their treatment there, and rather than go to the central part of Utah. So Patient-Centered Data Home is a way to basically share that information amongst the HIEs that serve those different geopolitical areas. So the HIE that services Colorado is connected with the HIE that services Utah, and we share information based off of the patient's address amongst the different HIEs. It's been very helpful and very successful because, once again, like we said, people don't necessarily follow geopolitical borders to get treatment, and there's a lot of things as well. Utah has a very well-known cancer institute that services a lot of the states in the western United States, and so there's a lot of referrals to Utah from other places, and it's the same way. Arizona has some specialty hospitals, Nevada as well. So people, I guess what it comes down to is that people don't always receive care where they live. Sometimes they have to go somewhere else to receive care, and that's what the goal behind Patient-Centered Data Home has been, is to help those patients that actually receive care at other places. So the big reason why we're talking today is the identity management. And once again, I kind of mentioned that the identity management, there's two parts to that. First, there's the patient matching, and then the second would be the provider matching. Knowing that first, the patient matching, knowing that patient A is the same patient that was at a hospital last week that's at a new hospital this week. That's the patient matching. But then the provider matching is knowing that, clinician A is the same clinician working at this hospital that works at this small clinic on the weekends. Being able to know that there's value there as well. And we use data from both the community as well as national databases to do our identity management services, and through that we're able to report back and provide information back to the people that are sending in data to our master patient index. So then they can use that data to determine duplicates within their system or resolve any identity issues that they have within their system. Yeah, it's been very helpful to be able to have that and be able to share that, and then having the connections with these national databases helps as well, because it's able, sometimes some data sources don't have very complete data, and being able to have access to those national databases has been helpful to be able to determine if we can match that patient or not. So the ThSisU program, it stands for the Shared Identity Services for Utah. And the goal behind it is to really improve healthcare and so to do that, the legislature authorized the Utah Department of Health to work on electronic identification of persons across different healthcare sources. So that has kind of been the goal and the focus of the ThSisU program. ThSisU is made up of a volunteer organization of public and private stakeholders. So there's people from, public sector like the Department of Health and state government, and then private organizations as well, like UHIN and some of the large healthcare providers in the state, as well as some of the insurance payers participate. The main goal and purpose of ThSisU is to define and develop identity services and utilities within the community, and then also to encourage the adoption of those identity services for data integrity, patient privacy, and efficiency. So that's the charter and the main goal of the ThSisU program. Kind of mentioned this before, but once again, the principal identity services are really to do identity management on patients, so a master patient index, and then also on providers, and be able to know which provider we should be sharing this information with. Maybe the provider works at a hospital, but then also works at a small clinic, and so we need to be able to know that and know, should we be sharing the data with the small clinic or with the large hospital system. A big driver of data exchange in the United States has been healthcare reform. I mentioned this before as well, that patients seek care across both organizational and geopolitical boundaries. So they might go to one organization this week, and depending on who their insurance covers or where the specialist is or what they need, where they need services, they may go to a different organization the next week. So patients go across different organizations, and data needs to be able to be exchanged amongst those organizations for the patient to receive the highest quality care. Currently, though, there are a lot of communication gaps that exist even within the same organization, but across organization, it's definitely very fractured, and the communication gap is very wide. And then finally, there's been a big drive with healthcare reform to improve quality and reduce cost. And to do so, it requires more of a holistic view and more of a community care coordination approach. And to be able to work together as a community to coordinate the care of a patient, interoperability and data sharing are required. So those are some big drivers of data exchange and that. The other part is that workflow automation is very important and is what is needed. A lot of organizations have implemented EMRs, and the providers don't want to have to go outside of their EMR to another system to be able to view or use data. They want to be able to use it within their system. So inserting the data in the correct point of the workflow is crucial. And it helps too, because then the provider has the most data that they need, everything that they need. Yeah. And then also having a shared utility helps increase the efficiency for data exchange. You know, if there is a shared utility, the stakeholders can actually share that infrastructure cost or cost to automate a process. And then they can also help improve the data integrity without having to build their own siloed systems and doing their own things. If a shared utility is there, then it really brings up the healthcare community, and you know, the investments in the cooperation help improve innovation and healthcare reform. Just like any type of a public utility, you know, streets or, you know, any type of really public infrastructure, it's kind of the same way with healthcare as well, that there is some shared services there that could be leveraged by different organizations, and any investment by anybody in the community helps improve the quality and reduce the cost across the entire community. So just a little history and background on the ThSisU project and also just healthcare reform. So the main goal of healthcare reform has been to shift care to be more focused on longitudinal patient-centered care. The American health system has been built very well around acute care and fixing something that's broken and then sending someone on their way, but not necessarily looking at the longitudinal picture and treating chronic conditions. So there's definitely a shift that needs to happen there. So the American Recovery and Reinvestment Act, or ARRA, funded incentives to start using electronic health records and to help improve healthcare information technology infrastructure within communities. So that was kind of a shot in the arm that helped improve healthcare reform and kind of move it forward. Along with that is that the Center for Medicare and Medicaid Services, or CMS, has put their funding around priorities for interorganizational data. So being able to exchange data amongst different organizations, that's kind of a shift that CMS has made. So after, while all these things were happening, the American Recovery and Reinvestment Act and the CMS shift, Utah designated UHIN as the statewide designated HIE and the independent exchange hub, so that there could be kind of a central broker, an organization there in the middle that would help facilitate all of this exchange. Out of that, the ThSisU project was kind of born and came from the legislature in the state of Utah to help build out those essential shared services that could be used amongst the community. And a big part of that is grants that are used to build that infrastructure for a specific use case. And using those grants help kind of lay the framework for the other shared services that can be filled in around it, but the grants really lead that. So the Center for Medicare and Medicaid Services has something that's commonly referred to as 90-10 funding. It's referred to that because the states will put up 10% of the money, and the federal government will put up 90% of the money. So basically, for every dollar that the state would spend on a CMS project, the feds will provide $9 to match. So it's been a very useful source, and that's actually money from the ARRA grants, the American Recovery and Reinvestment Act, as well. So that's been our main funding source and will be through 2021, at least for the last few years and up until 2021. So the different organizations within the ThSisU project kind of work on a lot of different parts, but a big part of it is getting standards for national open networks and participation in those networks. But those standards need to include elements around patient privacy and data security. So there's a couple different organizations that have worked on that. These are just a few of them. One is called Care Equality, another is Digital Bridge, and then the final is Healthcare Services Platform Collaborative. There's a lot of other organizations as well, the eHealth Exchange, that's part of Sequoia Project, several other groups that have really taken on this role of building a national open network with patient privacy and data security. One of the roles of the participating organizations is to really set the use cases and prioritize those use cases, and especially related to where we need a correlated identity and a correlated identifier, really. So the organizations that are really kind of driving that are the Utah Department of Health, the Utah Public Health Laboratory, the Utah Department of Human Services, and then Centers for Medicare and Medicaid Services, or CMS. So those organizations are the ones that have mostly been driving and helping prioritize the use cases and figuring out where we could start with the correlated identities and where it would be the most useful. We'll have kind of a slide later that will show a little bit more of some of the use cases and where we're at with those. So the participating organizations that have helped to build the technical infrastructure and work as clinical data sources, so that's been University of Utah, Intermountain Healthcare, UHIN with our multiple data connections with different providers, and then the Utah Department of Health. So that's who's actually kind of setting the technical infrastructure and getting the clinical data sources and whatnot. And then finally, the grant funding. We mentioned this before, but most of it is coming from CMS through the 90/10 funding. But then there's also grants from AHRQ, which is an organization that works around quality and quality metrics. And then finally, provider organizations themselves have also provided funding. For example, Intermountain Healthcare and University of Utah have provided some funding and in-kind services to help provide that infrastructure. So the biggest foundation of identity services and using identity services as a utility is really to correlate the patient identity and proof that patient's identity for healthcare purposes. And so what I mean by that is the correlation is first that, okay, is patient A the same patient that was at the hospital last week, or is it just a patient with very similar demographics? So that's the identity correlation. And then the identity proofing is, okay, is the patient that's in front of me actually the patient that they say they are? Are they patient A, or are they actually just someone that's, using a different name? Or do I have the wrong patient record in my system? So really kind of identity proofing. So the two differences there, it's a little bit of a nuance there in the difference, but they're very important and key parts of identity services is to be able to tell, one, across different organizations and across different encounters, is it the same patient? And then two, is this the correct patient that I have and the correct record for that patient? Another important part of identity services is having the provider connectivity and being able to receive their directory and their directory information. So knowing that a provider works at multiple different organizations and knowing how to contact them, for example, with the CHI alerts, knowing do they want to get it via an SFTP or do they want to get it via a direct secure message. Also important to identity services is care team relationship management for patients to providers. So knowing who is on the care team and being able to identify those people and who the information needs to be shared with, because the care team is usually more than just a provider. It's sometimes even a patient's relative or a different organization altogether. The fourth important part of identity services is patient proxy handling. And what I mean by that is that, for example, I have 3 children and I am somewhat of a proxy for those children. I'm the one that makes their medical decisions at this point because they're all very young. So being able to identify, first of all, that I, Cody Johansen, am the one that should be overseeing my children and have proxy access and provide that information, but then also kind of identifying that I have access over my children and not over my niece or my nephew, and that I'm not the one that necessarily makes that decision. And there might be some scenarios where I am the person. Maybe that child is living with me for whatever reason. So being able to really determine the patient proxy access and who could also be involved in this patient's care. And then finally, the fifth part is message orchestration for case management, being able to know who to share the information with and when to share it. You're not always going to need to share everything with every case manager, so being able to know when and who to share it with is also important, and knowing that that case manager is associated with that patient is important as well. So these are the foundational identity services and utilities that we've tried to work on with ThSisU. This is a little bit of a busy slide, but it just kind of shows the different parts of, over here on the left, we have a lot of different external connections. We have EHRs themselves. We have third-party vendors that do different services, and then we have networks, like we mentioned before, the Care Equality and eHealth Exchange, and then UHIN itself is a network. But then we also have kind of these integration broker services that are at different levels at all the different organizations. But then down here we have our statewide shared interoperability resources. This is where we have our state MPI built into. So it kind of just shows a little bit of the relationship of all the different pieces that are kind of used and work together. So once again, we talked about use cases, and this is the slide that I referred to earlier about the use cases. And so the way that this is read is over here on the left side is the use case, and then these are kind of different categories in each column here. So for example, the first column is, do you need to do patient identity proofing and verification for this use case? The second column, do you need to have provider electronic receiving specifics for that use case? Third is care teams. Fourth is patient proxy. And then the final one is case orchestration. Whoops. Sorry about that. So for example, for an electronic birth certificate, you do need to have patient identity proofing and verification. You need to be able to know that this, if you're creating that birth certificate, that it's for, that exact child that was born and that it's the correct child. You don't necessarily need a provider electronic receiving specification because the providers are usually the ones that would be reporting that, so they don't really need to receive that information back. Care teams wouldn't necessarily really get a birth certificate as well, but the patient proxy, for example, the patient's parent or legal guardian would need to be able to have part in that use case. And then finally, the case orchestration, there's not really a lot of case management that happens just for a birth certificate, right? Maybe for other issues that come on down the road. But so that's kind of how this whole diagram is met. And I'm not going to run through all these different scenarios, but I'll just run through this next one. So the second use case that has been identified by the ThSisU participants is screening orders and tracking and results. So for example, for a newborn, there's different screening lab results and orders that are done, hearing screening, there's blood test labs and orders and results that are done. And within that use case, the screening orders, tracking and results, it really needs all of these 5 different categories because you need to know that it's the right patient and that you're doing this on the right patient and that you've identified the correct patient. You need to know that the provider gets the results back so that they can know to follow up with the patient if there is an issue. The care team needs to be involved. A patient proxy could be involved as well. And then finally, case orchestration. So this just kind of goes through all these different use cases that we've worked through and the parts of ThSisU that they really need to be involved with. Yeah. So a lot of different use cases over here on the left, but once again, don't want to spend the whole time going over all these, but you can definitely look that over and see. So this is just a little bit of a roadmap of key infrastructure use cases that we have been working on. In 2018, we worked on quite a few different things. One of the biggest ones is the outside records for inpatient workflows. So if a patient is admitted to a hospital, being able to get information from that patient's PCP or from possibly even another hospital where the patient had been previously. Quite a few other use cases that we've been working on. In 2019, we're focusing on a few more of the use cases. Some of the ones that we have gotten the most traction on so far is for emergency responders, being able to share information with emergency responders, both information shared from the emergency responder to the receiving emergency department, but then also from the emergency department back to the emergency responder. So there's been quite a few different ones, and then the other one that's gotten a lot of traction so far is the newborn screening orders tracking and results, and we talked about those a little bit with, excuse me, possibly some screening orders, or, hearing screening and blood tests and whatnot. In 2020, one of our big goals is to focus on social determinants of health, legal relationships, kind of teasing out some of those issues that I mentioned before of, well, I should have access to my children's records, but maybe I go through a divorce and for whatever reason I should no longer have access to those records, or maybe I've adopted a child and should now have access to that patient's records. Dynamic external orders, being able to receive and get external orders, and then digital citizens, and then also a fall risk score of being able to determine if a patient is at risk for a fall. And then beyond that, there's, focus is going to be on simplifying and kind of getting rid of the onesie-twosie little one-off connections that have had to be made to fill gaps. So being able to bring things into the full infrastructure. So that's actually it for what I have. I believe that there might be some time for some questions then, Damián.
Yes, we have some questions that I was collecting from the other room. So if you're okay, I can start asking you those questions, and I will ask the audience if they have more questions. They can write it on the chat box, and I will read them to you in this.
Okay.
So the first one that I have here is, if you are using, what are the standards that UHIN or the CHI is using, and specifically if you are using FHIR? That was one of the questions.
Yeah, so the standards that we use are HL7, so FHIR is an HL7 standard. We have not really been able to use FHIR so much so far. We're trying to work on a few different projects with that, and with, for example, the newborn hearing screening, newborn blood screening, there's a part of that to use FHIR for part of the orders entry. But the most standards that we use are usually the HL7 version 2, the messaging standard, and then the HL7 version 3 CDA. And that's what we've used mostly so far. And to be honest with you, I think the biggest driver for that is usually because of the, that's what the EMRs usually support. EMRs have started to support FHIR a little bit more, so we're seeing a little bit more takeoff there, but it's usually been the HL7 V2 and the HL7 V3 CDA that we have worked mostly with.
Great, thank you.
Mm-hmm.
So one of the comments that we have here, this is like a great model if we could apply in Latin American countries, like this model of having like a central network to share information. And he was saying that this could be used there, or we could use like this example to write recommendations for the region. Do you have documents or information available that like people can access, like, I don't know, in the internet, or files that you can share with our audience?
Yeah, we definitely have some documentation that we can share, and I know that ThSisU has come up with a few other things, so we can work on getting you some information around that and get you that. I guess my question would be, is there something in particular that they're looking for, or something that that could help us kind of focus on what to provide?
Yeah. Yeah, and I think that they can always email me, or we have a site, LinkedIn site, where we share questions and things. So they can send me like more specific information about this question or about this need, and I can forward that to you guys if you're okay.
Yeah.
At least if you have background information on how how UHIN was created and how, or even like high level technical aspects of like the architecture and how the information is shared, I think that would be helpful.
Yeah, we'd be happy to share that, and we've got plenty of stuff to share. So we'd be, like it's kind of like we said in the presentation, we're supposed to be the community trusted exchange partner. So we're all about sharing and communicating with others. So.
Right. The other question is, how did you manage to access clinical data in the US, like for example these different electronic medical records, and if you have any experience where UHIN were not able to access to that data?
Yeah, so the first part of that question, definitely there's probably the way that we do it the most is either it's once again using the HL7 standards, version 2 or a CDA, and so we either push those messages directly to an EMR, or the other scenario is that a lot of EMRs support some protocols. One of the kind of national organizations that we mentioned was the eHealth Exchange, as well as Care Equality. So those groups have some specifications that they've taken from another group called Integrating the Healthcare Experience, or IHE, and they have specific kind of like protocols and stuff on how to exchange information. And usually the payload, though, is a HL7 version 3 CDA. So that's kind of the technical side, and how we usually do that is, and what has had the best adoption. And once again, that's been driven mostly by the EMRs and what the electronic medical records support and how they support it. And that's also been helpful because it's within the provider's workflow, so they're not having to go out of another system and view that information in another system. The second part of that question is, have we had experience with not having data shared, was my understanding from the question, and we definitely have experienced that. And there's kind of been two reasons behind that. Well, maybe three actually, to be completely honest with you. So the first one is just that the system that's being used, electronic medical record, just doesn't have the technical capability to share that information for whatever reason. It just wasn't built to share it, or it has it stored in a way that's not easily retrieved and shared. So there's kind of like technical limitations around that. I've seen most of those technical limitations go away. The second scenario is around kind of privacy and security concerns. So, there's a big concern about, in America, we have the HIPAA regulations, and you're only supposed to share the minimum data necessary to treat the patient and whatnot. And it's kind of a bit of a new world to have to share data with other organizations that then can share it with someone else, and not having control over that. So there's been some privacy and kind of security concerns that we've had to deal with. And then the final portion is really kind of competitive issues. So it's hard to get two organizations that are very competitive to come together and share information, because they feel like that information is what makes them different, right? The data that they actually have and how they use that data. So forcing them to have to share that information with each other can be difficult at times. So I think for all three of those reasons, we've seen data that hasn't been able to be shared. I think that a lot of those barriers are being broken down, and a big part of that is that in the United States, there's actually been changes to our regulations, and and whatnot to be able to facilitate the sharing of information more easily. But then also there's also been some penalties that have been put in place if information isn't going to be shared. So there's been kind of both sides, but I think those three drivers are kind of the biggest drivers of why information doesn't get shared.
Great, thank you. So the other question is, what is the information that patients can access from UHIN?
The information that patients can access, right now we have a patient portal that they basically can log on and they can actually view all of the information that any clinician could view. But you know, in the clinician's perspective, they can search for different individuals and view information for different patients. Excuse me, the patients can only view information on themselves or on someone that they should have proxy access for. So any information that's in the system, though, is shared with the patient as well. So whatever system we have and whatever system information the clinician can share, we share with the patient. And that's pretty standard with the way that things have moved with EMRs usually have a tethered patient portal that people can use to access that data, but it's only from that one organization. And so, you know, the UHIN patient portal has data from all different systems, but whatever's in there is able to be accessed. So, I mean, we have medications, allergies, lab results, clinical notes, encounter information, problem lists, all kinds of clinical data.
That's amazing. So all the information that the provider have access, the patient can access to, right?
Yep. Yeah.
Great. I have another question here that says, when a patient goes to the ER, which is or how like the provider in that facility can access to the patient data?
Yeah, so really there's kind of two ways to do that. One is we have a web portal that a provider could go and log into and pull up and search for that patient. What we've seen though is that usually doesn't get adopted very well, especially, I mean, providers are very busy and have a lot of things going on, so they don't want to have to go to another system. So what we've seen is usually more useful or more used is whenever from their EMR, they can do a query from their EMR to us. And those queries are based off of the standards from the eHealth Exchange and Care Equality that we talked about before and the IHE protocols. But their EMRs are basically able to do a query from their EMR to UHIN, and we're able to provide back the patient's information, and then they view that information in their EMR. And some of the EMRs are even now getting to the point where they can consume some of the information that's provided back. But that's usually the way that it's adopted the most. And I kind of talked about it in one of the slides about having it be in the workflow of the provider is the most important part. The provider doesn't want to have to leave their EMR and go to another system and look something up and view it. They want to have it in their EMR so that they can view it there. And so that's what we've seen has gotten the most adoption, especially in the emergency departments.
Great. And what are the technologies, or if you're using any like specific software to consolidate the information from these different sources? Can you describe which is that like system or software?
Yeah. So there's a couple different parts to it. So for our master patient index, we use a tool that is developed by IBM. It's called Initiate, and it's a standard kind of master patient index tool that is used at a lot of different places. We use an interface engine from a company called NextGen. It used to be, the company used to be called Mirth, and then Mirth was purchased by NextGen, and it was called Mirth Connect, the actual interface engine. But now they've rebranded it to be called NextGen Connect. But we use the interface engine to kind of receive the messages and process them through our master patient index, and then process them into our central data repository where the actual clinical data is stored. And then for the central data repository, we use another product from NextGen that used to be called MIRTH results, but now is called NextGen Results CDR. So we use those different pieces, and then there's the direct secure messaging. We use another vendor called Secure Exchange Solutions for the direct secure messaging. But the main parts of the actual clinical records exchange are the interface engine, which is that NextGen Connect, the master patient index, which we use IBM Initiate, and then the central data repository, which is the NextGen Results CDR.
Great. Do you have an idea of how many messages or documents do you exchange or do you receive daily?
Yeah, I mean, I guess that number can be a little hard to say. So as far as actual like CDAs, clinical documents, we usually have about 50,000 per month that are exchanged, and that should be increasing as we bring on a few more organizations that can do that query from their EMR directly. But usually about 50,000 per month. Per day, we usually receive anywhere from about 100,000 to 200 to 300,000 messages, and those would be HL7 version 2 messages as well as HL7 version 3 CDAs. So we get a lot of messages every day, but then people actually accessing it, it's probably about 50,000 per month that people are actually pulling a record and viewing a record.
Okay, and I have one last question, at least for now.
Mm-hmm.
One is for one of the leaders in our network, Alejandro Justi, and we are working, or one of the aims of our network is to develop like a toolkit to help countries to implement electronic medical records and all the components that are needed in order to implement like national electronic medical records. And one of the things that we want to like mention there are the problems or potential problems or difficulties or challenges that people face when it's like dealing with this type of project. Can you describe like the main challenges that you face or that the UHIN face during the development of the network, or just working with EHRs, working with healthcare organizations, that type of things?
Yeah, so definitely. I guess I would echo the three things that I mentioned before on why we don't get data at times. So there was, the three different reasons. One was that just the EMR didn't support it or didn't have a way to do it. So there was some type of a technical reason why it didn't happen. A lot of that has gone away. But then the other two were privacy and security concerns of, okay, should I share this information and should I not, and who should I be sharing it with? And then finally, the kind of competition concerns and the kind of business side of healthcare of, well, that's my competitor, so I don't want to share information with them. Those are definitely three big issues that we've kind of run into in developing the UHIN network and getting people on board. The other big thing that I guess I would say is it's kind of a resource constraint issue, and what I mean by that is that all of these organizations that are working have their own internal processes and their own internal issues and projects to work on. So usually the HIE is at best like the second option of what needs to be worked on, right? And that's completely understandable. An organization needs to make sure that it's functioning and that it works. And, if their EMR system goes down, then they need to fix that. But then also they need to get different information systems within their organization sharing information. So they're going to work on that before they work on sharing information with an external organization or an HIE. So I think there's been a lot of issues with kind of resource constraints on just the provider side on maybe the IT department with the hospital or with the provider, or even with the electronic medical record itself. You know, a lot of electronic medical records just don't have the resources to be able to make connections all the time. So we have to get in their queue, and then we have to wait, 2 or 3 months before somebody at the EMR vendor can even work on it. So other than the 3 big ones that I mentioned before, I think the 4th big issue would be resource constraints and kind of resource prioritization. The HIE is always an external organization, so it's going to take, it's always never going to be priority number 1. Yeah.
And what about confidentiality issues, and how do you UHIN manage, like, for example, to grant access, like,
yeah, so
or if a patient doesn't want to share his or her information with a specific provider, how do you deal with this type of thing?
Yeah, so I guess probably the stance that we've taken is that it's an all or nothing, right? So it would be very complicated to be able to say, hey, this patient doesn't want to share this information with this specific provider or with this specific person. So what we've done is we've just taken an all or nothing approach, that it's, well, all of your information is going to be shared and it could potentially be accessed by anybody, or you say that you don't want any information accessed at all. So it's kind of an all or nothing, yes or no, I'm going to share my information or I'm not going to share my information. And I think we've kind of had to take that stance because it would just be, too difficult to be able to handle the confidentiality and the privacy of sharing it individually with, oh, I want to share with this doctor but not this doctor. And then, that probably has been one of the big hurdles to get over, is just the trust that people have with that. One way that we've kind of gotten around that is we've basically specified specific use cases that we can use the information for from the system. And if it's not one of those use cases, then we don't share the information. So, for example, the medical examiner wanted to be able to start accessing records to be able to improve their determinations of a cause of death. And so we had to go, because that's not covered under the HIPAA regulations of treatment, payment, and operations. So we had to go to our board of directors and approve an additional use case to where the data to where a medical examiner could access data. And as part of that, we had to get it approved by the board, but then we also gave the data sources the option to opt out from that so that they could not share that information. So I think it's a lot of different pieces to that. One is kind of defining the specific use cases and who can and can't access it, and then giving the data sources the option, but then also giving the patient the option, but at the same time not giving them too much of an option to where, oh, well, they're going to specify, I want to share with this provider but not this one. Just saying it's either an all or nothing. So
great, thank you. I have 2 more questions, and I think we need to finish because we are almost on time, but I think these are really relevant questions, so I would like to see if you can answer them. The first one is, if you have, and I think this is like a big difference with other countries in the region and in general, is, do you have a national identifier that you use to identify patients, or do you use like an algorithm, or how do you identify patients?
Yeah. So we don't have a national identifier. There's what we call the Social Security number that citizens have, but that kind of causes issues because if it's someone that's not a citizen, then you don't necessarily have a Social Security number. So we do not have a good identifier that's in the United States, to the point that the government has actually mandated that CMS, the Centers for Medicare and Medicaid Services, cannot have a national identifier. So anyway, so what we do is we use an algorithm, and that's what that IBM Initiate product that serves as our MPI. It uses demographic information, and it uses, name, first name, last name, gender, date of birth, social security number, address, and phone number to try and calculate and basically determine is John Smith from this organization the same John Smith as the other organization. And it uses, a highly complex algorithm to basically determine that, and it weights the different components based off of how common they are and whatnot. So it's a pretty complex system, but it definitely adds some issues to that. So if there were a national identifier that could be used, it would resolve a lot of the issues that we run into. But yeah, unfortunately we don't. So we end up having to use something like this Initiate product that has a really complex matching algorithm to be able to determine if it's the same patient or not.
And there's another question that says if you can do some family research around diseases, like for example, because you have the information about family members, right? And you have these identity services. So with that information, would you be able to do disease research, like for example, knowing which diseases are part of a family, for example?
I mean, theoretically, yeah, we could do that. I don't think that we have ever leveraged that quite yet. I mean, the HIE has been around for 10 years, but it's still, probably within the last 3 to 4 years, we've just started to get a lot of the data sources connected. So it's still trying to kind of figure out how to use it. But I mean, theoretically, yes, since we have the patients in the system and we should be able to identify, familial relationships, we should also be able to look at, diseases that might have a genetic component or that have, happened across patients. So theoretically, yes, but in practice, we have not done any of that.
Okay. So I think we have some questions or comments that are around if we can get access to the documents, but I think that's something that we can, if you send me that information, I can distribute it with our network, and I think that would be enough. So, and we are on time. So I would like to thank you, Cody, for doing this presentation. This was very informative, and I think would give us a great source of information to start planning or to work in similar ways in some of the countries in the region. So
okay,
Cody.
Sounds good. Yeah, thank you.
And thank you everyone in the WebEx, in both rooms, in the English room and in the Spanish room. Thank you, the translator, for doing this work. And thank you, RELACSIS and all the team there too. And see you. We have the next presentation next week on Tuesday. Alejandro Lopez Osornio from Argentina is going to do the presentation, and the topic would be standards and specifically FHIR. So there was some question today about that standard. So if you're interested, please come and join the presentation. He will be talking about the use of FHIR to identify patients. So thank you everyone, and see you next week.
Thanks.